Hello everyone, I'm Shabana this side, and this video is on cervical CERCLAGE. This is based on the new Green Top guideline. This is also a very important topic from examination point of view. So regarding cervical CERCLAGE, it helps to prevent a mid-trimester loss or preterm birth. It is an invasive procedure and it has some risks. So before offering it to women, we need to make sure that the likely benefits outweigh the potential harm. How does it work? It helps to maintain the structure and the length of the cervix. It also helps to maintain the endocervical mucus plug, which is important to prevent ascending infection. Indications for cervical CERCLAGE. There are mainly three indications. One is history-indicated CERCLAGE, ultrasound-indicated CERCLAGE, third is emergency or rescue CERCLAGE. History-indicated CERCLAGE is offered to women with history of 3 or more previous preterm births, and now they have a singleton pregnancy. Ultrasound-indicated CERCLAGE is offered to women with history of 1 or more previous mid-trimester loss or preterm birth, and now they have a short cervix on ultrasound scan. Short cervix means cervical length is less than 25 millimeter. Regarding emergency or rescue CERCLAGE, basically it is physical examination indicated CERCLAGE. It is offered to women with painless cervical dilatation in second trimester without any evidence of preterm labor or placental abruption. It may delay birth by approximately 34 days in some cases. However, there is limited data to support any improvement in neonatal mortality or morbidity. There is high chance of failure if cervical dilatation is more than 4 centimeter or if there is membrane prolapse beyond the external os. What are the contraindications for cervical CERCLAGE? If the woman is in active preterm labor, there are signs of chorioamnionitis, there is ongoing vaginal bleeding. If the woman has preterm pre-labor rupture of membranes, that is PPRM, there is fetal compromise, lethal fetal defect, and intrauterine fetal death. These are all contraindications for CERCLAGE. What about indications for ultrasound scan measurement of cervical length? So ultrasound scan surveillance is indicated in women who are at high risk of preterm birth and who are at intermediate risk of preterm birth. So women who are at high risk of preterm birth, they are women with history of preterm birth or second trimester loss between 16 to 34 weeks. And if they had history of PPROM at less than 34 weeks, history of previous CERCLAGE, known uterine variant or anomaly, intrauterine adhesions, and history of trachelectomy. How do we manage them, and what about the scan surveillance in this group of women? They should be reviewed by a preterm prevention specialist by 12 weeks. Transvaginal scan should be offered for serial cervical length measurement every 2 to 4 weeks between 16 to 24 weeks. Who are the women at intermediate risk of preterm birth? They are the ones with history of cesarean section at full dilatation of cervix, history of cervical surgery like Let's procedure with an excision depth of more than 1 centimeter, or more than one Let's procedure, or history of cone biopsy. How are we going to manage them, and what about the ultrasound scan surveillance? They should be offered at least single transvaginal scan for cervical length measurement between 18 to 22 weeks. So practically it can be done at the time of the anomaly scan, that is at 20 weeks of gestation. Timing of insertion and removal of CERCLAGE. For the history-indicated CERCLAGE, it can be inserted between 11 to 14 weeks of gestation. Before the insertion, first trimester ultrasound should have been done to confirm the dates, to confirm the viability of the baby, and to confirm that it is a singleton pregnancy, because CERCLAGE is not offered to women with multiple pregnancy. Screening for aneuploidy to rule out any chromosomal anomaly should also be done. For emergency or rescue CERCLAGE, it is done at the time of diagnosis. We have to ensure that anomaly scan has been done to rule out any fetal anomaly. Also, we need to rule out any intra-amniotic infection. And if needed, women may be offered blood test to check for the white cell count or the C-reactive protein. CERCLAGE should be removed between 36 weeks and 1 day to 37 weeks. If the woman is an established and active preterm labor, it is removed immediately. Removal could be delayed until the time of elective cesarean section. What about cervical CERCLAGE removal if there is PPR-ROM between 24 to 34 weeks? If there is no evidence of infection or there is no preterm labor, we can consider delaying removal of CERCLAGE for at least 48 hours to facilitate in utero transfer and to offer corticosteroids for fetal lung maturation. If there is any evidence of infection or woman is in preterm labor, CERCLAGE should be removed immediately. PPR-ROM at less than 24 weeks or more than 34 weeks of gestation. At these gestation age, we have to remove the CERCLAGE because it is unlikely to be advantageous. The types of CERCLAGE procedures, we know it can be done through transvaginal or transabdominal route. In transvaginal CERCLAGE, the CERCLAGE or stitch should be placed as high as possible on the cervix. It can be placed either with bladder mobilization, that is the Shirodka procedure, or without bladder mobilization, that is the McDonald procedure. Regarding the transabdominal CERCLAGE, it can be done by the laparoscopy, which will be having less risk of complications, or by laparotomy. Indicated in women with previous unsuccessful transvaginal CERCLAGE, it can be performed preconceptually or in early pregnancy. Preconceptual procedures, they may be more effective and are not associated with fertility, may be technically easier, they will be having lower anesthetic and fetal risk. Very important, all women with transabdominal suture will need a cesarean section for delivery. And abdominal suture can be left in place after birth if a future pregnancy is planned. What are the complications of cervical CERCLAGE? So women should be informed about these complications and they should be given the patient information leaflet as well before taking this procedure. There is a small risk of intraoperative bladder damage, cervical trauma, membrane rupture, and there is risk of bleeding during insertion of CERCLAGE. There is risk of cervical laceration or trauma if there is a spontaneous labor with the suture in place. If high vaginal CERCLAGE was placed and it was inserted with bladder mobilization, that is, Shirodka procedure was done, then it usually requires anesthetic for removal, and therefore it carries the risk of an additional anesthetic. Now, what about the management of women with transabdominal CERCLAGE and delayed miscarriage or fetal death? So here the decision making is complex. We need to involve the senior obstetrician. There are 3 options in such cases. Complete evacuation can be done through the stitch by suction curettage or by dilatation and evacuation in early weeks of gestation, that is up to 18 weeks. Or we can cut the suture through a posterior colpotomy to aid with the delivery. If this fails, then we can offer hysterotomy or cesarean section. What about the operative issues? What about giving tocolytics routinely? No, it is not recommended. It should be given on an individual basis. Likewise, prophylactic antibiotics is given at the discretion of operating team. Regarding anesthesia, the choice should be made by the operating team in conjunction with the woman. Both general and regional anesthesia are safe, and elective transvaginal CERCLAGE can be safely performed as a day case procedure. Suture material should be non-absorbable. What about 2 versus 1 single purse string suture? There is no difference. What about cervical occlusion suture? In addition to primary CERCLAGE, it is not routinely recommended. Coming to the post-operative care, bed rest and abstinence from intercourse is not routinely recommended. Post-CERCLAGE serial ultrasound scan for cervical length measurement. So here we have to see if it is history indicated CERCLAGE, it is not done routinely. But if it was ultrasound indicated CERCLAGE, then we may offer the ultrasound scan after the CERCLAGE. It may be useful in individual cases for timely administration of steroids or in utero transfer. What about emergency CERCLAGE after an elective CERCLAGE or ultrasound indicated CERCLAGE? Decision should be made on an individual basis. Fetal fibronectin testing and progesterone supplement is not routinely recommended. Now, should women be offered progesterone or an Arabian pessary instead of a CERCLAGE? There is still no evidence that either progesterone or Arabian pessary alone is more or less effective than cervical CERCLAGE. Data are currently lacking, but trials are ongoing. Some special cases. What about multiple pregnancy? CERCLAGE is not recommended. If the woman has cervical surgery, any cervical trauma or uterine anomalies, and no additional risk factors, role of CERCLAGE is uncertain. Women with high BMI, yes, CERCLAGE is effective. What about incidental finding of short cervix on the scan where the cervical length is less than 25 millimeter and there is no additional risk factors? CERCLAGE is not recommended. What about isolated finding of funneling on ultrasound scan? That is dilatation of the internal os without cervical length shortening. Again, CERCLAGE is not recommended. I hope this was helpful and thanks for watching. I shall be uploading more videos from examination point of view. So do look out for them and hoping to see you soon with my next video. And until then, goodbye, take care, happy studying, and happy revision. Thank you.